We have a packed agenda today covering lots of topics related to working with DC's Medicaid managed care organizations, topics related to integrated behavioral health care, and how those two topics are related. Let me start with some housekeeping items and then we'll dive right into the workshop. I know many of you are very interested in educational credit, and I made an announcement about this earlier. There's two types of credit. If you're looking for continuing educational credit for social workers, you do need to sign in at the front desk, and when you leave at the end of the day, you'll sign out. You don't need to sign in and out for every session or for lunch, just once when you get here and once when you leave. If you're asking for continuing medical education credit, you do not need to sign in and out. Secondly, in your packet is a blue evaluation form. If you're requesting credit, we absolutely have to have that filled out. That's what triggers it. If you're not asking for credit, we still want you to fill it out. We're going to read I personally, you have my word, will read every single one of those. So you can write a note to me, Dr. Glossa, we think you should have done X, Y, Z, and I will see it. It's really important. We want everybody's feedback. A lot of work and resources and time went into this, so if we didn't meet your needs, we really want to hear that, because we will have opportunities to provide other workshops and webinars, and so definitely want to hear that. For CME credit, the CME credit is provided by Health Management. The certificates will be mailed within 10 to 12 days, and you'll be able to get your CEU credit from the Department of Behavioral Health Training Institute. For those of you that are asking, or will be asking for copies of today's slides, absolutely they will all be available to you. We'll either be emailing them to you, or they will definitely be available on the Integrated Care DC website, which hopefully all of you are very familiar with. You can go there for all kinds of information and recorded webinars and all of those things. So the slides will definitely be available to you there, as well as handouts. So even if you didn't go to one of the 3 breakout sessions, which we'll talk about later, the handouts from those and the slides will be available to you too. Here are today's learning objectives. First, because we're offering educational credit, we want to be very clear that none of us have any financial disclosures or any conflicts of interest. So the learning objectives today, we're going to cover topics on understanding the foundational elements of managed care, understanding how various collaborations can impact client outcomes, understanding your organization's value when partnering with managed care organizations, and lastly, understanding the importance of making sure clients are served at the level of care that best meets their individual needs. A quick review of the agenda today. We're going to start with opening remarks from DHCF and DVH leadership, Dr. Bazron and Director Byrd, who will give their leadership perspectives on the imperative for this payment and practice transformation. Then I'll be joined by my colleagues from Health Management Associates to walk us through managed care concepts, starting with a brief background context, foundational elements, and moving through more complex issues of population health management and approaches to value-based payment models. Each of those 2 sections will include a small group exercise and lots of time for questions. During lunch, we'll hear from a panel of managed care executives, clinical leadership, talking about their approaches to working with providers, to all of you, to improve the models of behavioral health integration. Lunch will be here in this room. You'll pick up your box lunch, take a quick 30-minute break, and feel free to bring your lunch back in here to finish it as the panel starts. After lunch, we'll move into the 3 breakout sessions. I'll explain more about that later. 1 will be in this room, and 2 will be upstairs, and I'll give you a brief description later to help you choose which breakout session. And after the breakouts, we invite you all to come back here for a quick wrap-up where we will report out from the breakout sessions, as well as talk about next steps. Okay, lots of housekeeping there. And coffee and bagels are available all morning. Please feel free to get up, stretch your legs, and help yourself to that. So with that, let me introduce today's first presentation. Our presenters, who need no introduction, are Dr. Barbara Bazron, Director of DC Department of Behavioral Health, and we're starting with Director Melisa Byrd, Director of Medicaid. So thank you.
Good morning.
Good morning.
Okay, we're going to do it one more time. Good morning.
Good morning.
Thank you, Dr. Bazron. Too loud and clear. Always there to support us. Good morning, everyone. My name is Melisa Byrd. I'm Medicaid Director here for the DC Medicaid program. This may very well be the first chance or opportunity I'm getting to meet some of you in person, I think. Dr. Bazron was so gracious to invite me to, at that time, the weekly provider meetings, I think starting back in August 2020 in the public health emergency. And since that time, I've had the great opportunity to see most of you on a pretty routine cadence, but not in person. So for those that I see regularly on those meetings, it's great to see you in person. Hopefully I'll get a chance to say hi face to face as well. So it's great to be here today. I really do feel like today marks a milestone for us and all the work that's underway that we will be bringing together, you all, the providers, and our managed care plans for the Medicaid program. This is really just the first of what will be a pretty intensive collaboration over the next several months as we prepare for the carve and services. When I write these things, it's always when I struggle, then I realize, well, if I'm struggling with my writing, then something's not right. So I try to take a step back and figure out why that is, and where can I get to that better place. And so I have struggled with my remarks today, and the framing I was given is to talk about the imperative for payment and practice transformation. And there are just infinite reasons why infinite reasons that I can give for the why. There's a ton of research, there are articles, you could explain why as well. But for me, when I think about the work that we're doing here at DHCF, and then very specifically the work here, there really is a core reason that's fairly simple for me. So in DC, our Medicaid program covers about over 300,000 individuals right now. And that's a historical high for the program. If you look at other Medicaid programs, that number is going to be really small, but our percentage of covered lives is really large. We're almost at 50% of the district's population in terms of the programs we administer and the number of folks that it covers. And so Medicaid beneficiaries, of course, live throughout all 8 wards of the city, but there are wards with a disproportionate share of Medicaid beneficiaries. So first I'm going to ask everyone, which ward do you think has the smallest percentage of Medicaid beneficiaries? I hear a lot of 1 and 2. I heard of 3. If you said 3, it is Ward 3 has our smallest percentage of Medicaid beneficiaries. So opposite of that, which ward has the highest percentage of Medicaid beneficiaries? Okay, everyone knows who we're talking about, and that's right, it's Ward 8. And so getting back to that reason of why, so we know we have the fewest Medicaid beneficiaries in Ward 3, and for folks in Ward 3, their life expectancy is 87.6 years. We have the most Medicaid beneficiaries in Ward 8, and life expectancy in Ward 8 is 72 years. It's a 15-year difference. And I don't even think there's a way to articulate that. It's just nonsensical to me. It doesn't make sense. It is wrong. And so that is really the why. That is why we have to change the what and how we deliver healthcare services through the Medicaid program. And this disparity is what drives our work today, tomorrow, until we eliminate the disparity and are confident that we're providing residents the supports and services they need to be actively engaged in their health and to thrive. And we believe that the future we aim to create includes a healthcare system that supports whole person care. And when whole person care cannot be achieved, I feel very strongly about this, both personally and professionally, without transformation of our behavioral health services and system. And that's why the collaboration between the Department of Healthcare Finance and the Department of Behavioral Health is imperative, and why we are here today in partnership. When we started Medicaid behavioral health transformations around 2018, 2019, we wanted to address systemic issues that became more apparent through the opioid epidemic, including key service gaps in the Medicaid array and the complex and overlapping oversight that makes it harder to manage services. You all know that well. You deal with me, you deal with Dr. Bazron and DBH, you deal with managed care plans, you deal with all the on the fee-for-service side and sometimes the MCO side. Sometimes it's for some services here and some services there. And so we're really wanting to kind of get more streamlined in how that oversight works. Our first phase really did focus on the 1115 waiver, the behavioral health transformation waiver, and filling in some of the service gaps. And the second phase, which we are in right now, is integrating behavioral health services into the Medicaid managed care program. So I always think it's important to stop for a moment and talk about integration. There are several ways you can define or apply the word integration. And I think it's really important to clarify today what that means when we talk about behavioral health integration. And really right now is that we are looking to have that single point for oversight and operations of behavioral health. That means care coordination is coming from a single point, authorization is coming from a single point, that we're creating a whole picture of a person so that at least one entity And in this case, as we move into Carbon, is a managed care plan that has the whole picture. That's how I define integration today. And we are aligning the payment for physician and behavioral health services into the same delivery system, and the work we are doing now is foundational and a very important step towards moving towards a more integrated system of care. Once we integrate the provision of services into Medicaid managed care, or we carve in, as we like to call it here, our definition of integration will change. This is not the forever integration getting to this point. And then we will move forward with designing an integrated Medicaid system that provides a truly interconnected system of providers that can be more proactive to address the whole person and respond to the person's continuum of care from birth to adolescence to mid and end of life. And so with that, I will invite my colleague, Dr. Barbara Bazron, up to give a few remarks as well. Thank you so much for your participation today, and I appreciate all your commitment and support of the Medicaid program. Dr.
Everything? Good morning, everyone. Good morning. And I want to say Happy Nurses Day week. You know, we all went through COVID, and we know how important nurses have been in that process. And so I really want to make sure that, you know, if you know a nurse, congratulate them and thank them today. And we have the whole week to do that. So let's really do that. And the other thing I'd like to say is that I have been with many of you over the past 2.5 to 3 years, but it's always been like this. And so it's really good to see people in 3D today. And so I'm really happy to do that. The Department of Behavioral Health is working very closely with the Department of Healthcare Finance to transform our behavioral health care system. And I can tell you that Melisa and I have literally been linked at the hip. I mean, we speak every single week about this, and we talk frequently during the week about transformation. This transformation effort will be implemented through the full carve-in of behavioral health into managed care. The managed care organizations contracted by the Department of Healthcare Finance will deliver physical and behavioral health care to beneficiaries through a fully integrated service delivery model. You've heard that before, right? We're going to do it here in DC. And I think that that's important. DBH will redesign its existing portfolio of behavioral health care services to support whole person care to achieve better health outcomes. The basic tenets of whole person care model is that health and wellness are not limited to one's physical health status, but are related to all aspects of a person's care that impacts well-being. Communication, coordination, and collaboration are 3 critical components of whole person care management, which assures that beneficiaries receive comprehensive and integrated care that addresses all of their needs. The expectation is that all behavioral health care services provided through this model is person and family centered and culturally responsive. The key elements of this model include the integration of physical and behavioral health, addressing the social determinants of health, and we've heard that word a lot, and that is a part of well-being, and the multiple factors that promote either health or disease. The ultimate aim of this effort are to achieve better health outcomes, support innovation in the delivery of care, improve service quality, and move towards a value-based, cost-effective behavioral health care system. DBH will also expand the range of behavioral health services it provides to district residents by implementing population-based behavioral health approaches. Through these efforts, non-clinical interventions and activities intended to improve behavioral health outcomes and the determinants of these outcomes will be provided.
This means that residents with mild to moderate behavioral health concerns that do not meet the clinical criteria for mental illness, substance use disorders, or co-occurring behavioral health disorders will be provided to provide the support that our residents need. We're all aware that during the COVID-19 experience, many of us have and still have the lasting impacts of going through the pandemic. Many of our residents experience high levels of stress related to isolation, grief, loss, and trauma, and community members who did not feel that community members who do not feel that the level of their need is consistent what the services are that are traditionally provided by the Department of Behavioral Health, have expressed the need for tools, resources, and consultation that support their behavioral well-being. A population-based behavioral health approach will be utilized to collect and analyze data to determine the specific needs of our community and craft and deliver appropriate services to address identified needs. This may include prevention and intervention services that are tailored for the worried well. This means that we have to really get upstream so that we can provide the services and supports that people need, rather than waiting until they are deep in disease state before we provide the services they need. We gotta move back to prevention, intervention, and psychoeducation so that we can get information and support to our residents. The Department of Behavioral Health, as you know, is the behavioral health state authority for the District of Columbia, and currently provides a full range of services for individuals with severe and persistent behavioral health issues. We also provide emergency, urgent psychiatric care, and safety net services for the priority population. This includes things like our clinic at 35K or at Howard Road for our young people, and our CPEP services. DBH also manages St. Elizabeth's Hospital, the district's public state psychiatric hospital. The system transformation that is currently underway as a result of the carve-in will allow DBH to implement its full statutory authority as codified in the Department of Behavioral Health Establishment Act of 2013. In accordance with the statute, DBH, as the full state authority, is responsible for the regulation of behavioral health services to ensure quality and network adequacy, conducting behavioral health education activities for the entire community, something we haven't done a lot of, providing information to the public regarding disease prevention and health promotion, another thing we got to step up, ensuring the provision of recovery-oriented system of care for residents with mental health disorders, addiction, and abuse of alcohol, tobacco, and other drugs, developing and maintaining an efficient and cost-effective behavioral health financing system, and lastly, establishing, implementing, and evaluating the district's strategic behavioral health plan. And that is something that we will be working with you to develop on an annual basis. DBH will continue to determine the standards of clinical care and the provision of quality oversight for behavioral health services. We will continue to be responsible for certifying behavioral health care providers. We will continue our strong partnership with the Department of Healthcare Finance to ensure that all services provided by the Behavioral Health Provider Network are aligned with DC regulations and guidance. The engagement of DBH in the MCO oversight process will leverage our agency's behavioral health expertise to provide optimal care to Medicaid beneficiaries. A memorandum of understanding between DBH and DHCF specifies our roles, the relationship, and the joint oversight responsibilities of the MCO behavioral health services. This is an exciting time for all of us within behavioral health. We have the opportunity in the District of Columbia to establish a system of care that is of high quality and truly integrated in partnership with our provider network, managed care organizations, and government partners. I know that together we can make a difference in the lives of all of our residents, regardless of their level of behavioral health needs. I am really looking forward to this challenge and this wonderful opportunity. And so thank you for allowing me to be here with you today.